My dear colleague, my dear friends, in this hard time for mankind, I thought I could entertain you and by giving you a talk on the kinematic alignment technique for implanting the medial uni. My name is Charles Riviere. I'm a hip and knee consultant working between London and Bordeaux, and I'm part of the MSK lab, which is part of Imperial College London. As you know, for total knee replacement, there is a paradigm shift happening with a switch from systematic implantation for more personalized and physiological, known as kinematic alignment technique. So the same is happening with the uni. The uni implant may be kinematically aligned as well, and I will explain you this later during this presentation. The simple definition of kinematic alignment is to do a true resurfacing without any ligament release. The goal is to restore the native orientation and height of the articular surfaces. A more complex definition is that we align the implant on the knee kinematic axis that dictate the motion of the tibia around the femur. The main axis is a cylindrical axis, also known as the transcondylar axis. The kinematic technique for uni has been devised decades ago by my friends Philippe Cartier. It was not named a kinematic alignment, but it follows the same principles. Therefore, there are two techniques to align uni components. One is a traditional mechanical alignment technique. It is systematic and it is not physiological. The slope is systematic between the patients, and implants are aligned alongside the long bone from mechanical axis. The other technique is the kinematic alignment technique, personalized, physiological, reproducing the anatomy, reproducing the individual medial plateau slope, and as you can see, implants are aligned alongside the knee kinematic axis. This is how it translates into radiograph. It is important to understand that the two techniques are different. Only the flexion of the femoral component and the axial rotation of the tibia component follow the same guideline. Every other steps in the implantation are different. While the kinematic technique preserves the physiological biomechanics of the medial knee compartment and the whole knee, the AMA technique alters. There are multiple advantages in doing a kinematic implantation. First, it preserves the bone stock on the tibial side. Second, it's better load the tibial bone toward the metaphysis, which may reduce the risk of fracture and pain because of bone remodeling. Third, it creates a better, more physiological soft tissue balance because you preserve the individual tibia slope. This helps you to restore more physiological soft tissue balance. Fourth, it generates a better dynamic component interaction between the tibia and the femoral component. Throughout the range of motion, implant remain perpendicular, which is good to reduce complication related to edge loading, which is wear of a fixed polyethylene bearing or dislocation of a mobile bearing. Then it reduces the shear stress on the tibial component interface, fixation interface, because when the tibia component is kinematically aligned, the implant remains more parallel to the ground during loading, so standing, walking. This reduces shear stress on the fixation interface between the bone and the implant. Last, it generates a better fit between the implant and the supportive bone. By fit, I mean there is less risk of implant overhang or bone under coverage. To illustrate, here you have a mechanically aligned medial uni, Oxford. The green line represents the kinematic cut. The red area represents the amount of bone that has been wasted because of the mechanical cut. The loading of the tibial implant is toward the inner cortex of the tibia, which may create complication, pain, or fracture. The two implants are now perpendicular one to the other, which may create complication because of edge loading on the liner. If you do a kinematic implantation, you don't have this complication. The load is towards, you may have, but it's probably reduced them. The load is more oriented toward the metaphysis. The two implants remain perpendicular one to another throughout the range of motion. The performing of the kinematic unit with the Oxford is relatively simple. After a classic approach and cleaning of the osteophyte, you do the tibial cut first. I personally do it freehand, but you can help yourself with the instrumentation to get more reproducible if needed. So the frontal and sagittal orientation of the cut follows the blue and the yellow line. The blue line is the anterior-posterior axis of the flexion facets of the medial condyle, and the yellow line, it's a K-wire that you put within the joint line on the anterior and posterior rim of the medial plateau, and this gives you the slope, the posterior slope of the medial plateau. By following those two lines, you perform a kinematic tibial cut. Then you observe the slope, posterior and medial slope of your bone cut. You measure it to make sure you remove enough. Then you move to the femoral preparation, the axial and frontal orientation of your femoral component will follow the blue and yellow line. The blue line, like for the tibia, represent the anteroposterior axis of the flexion facet of the medial condyle, and the yellow line, it's a K-wire that you put alongside the medial wall of the medial condyle, and that will give you the varus valgus orientation of the condyle. I also use a line that I drew on the skin and that represents the mechanical axis of the femur. I draw this line during positioning of the implant when I position the patient, and usually when you have a varus, medial knee arthritis, the femur is a few degrees valgus oriented relative to this mechanical axis of the femur. So I use a K-wire and the line and I draw on the skin in order to get more accurate. Then you do your cut, make sure the thickness is right. That should correspond to the implant. Consider thickness considering the loss of cartilage and the 1 millimeter of the saw curve. Then you balance flexion and extension gap, and then you rim your distal femur in order to get equal balance between the 90 and the 10 degree knee flexion. You do your finition, and this is the final implantation. You can see in extension and flexion how the implant remain perpendicular one to another. This is how it translates into radiograph. You can see on the AP view how the Cartier angle has been well maintained. But this is not only in the frontal plane. Kinematic implantation for uni, it's like for total knee, it's happening in the 3 planes. We published last year this study. We compared the alignment and the fit to the bone between AMA and KA techniques, and we thought that so if you look at the graph, the red dot corresponds to the AMA technique. This is systematic. Every patient has the same orientation of the implants. And the blue dots correspond to all the KA simulation. You can see how it varies between patients. So the tibial implant was on average 3 degree varus. This ranged from 0 to 8 degree. And the mean slope was 6.4 degree posterior slope. And this ranged from 0 to 12. For the femur, the mean orientation in the frontal plane was 3.6 degree valgus, and this ranged from 1 degree varus to 7 degree valgus. And we saw as well that when you do a kinematic implantation, the fit to the bone was better, with less risk of implant overhang or bone under coverage. We also ran a systematic review, trying to screen in the literature studies that may have compared the two techniques, KA and AMA. As I said before, the KA technique has been done for decades, mainly in France and Italy countries, but many other places as well. And so we found 9 studies that reported, so 9 comparative studies pulling almost 600 uni per group, and who compare the K and the MA technique. The authors never compare as a primary goal the alignment, but they compared 2 different implant design, and it happened that those implants were aligned in a different way, either MA or KA. As you can imagine, it was difficult to compare the value between the 2 techniques because there were a lot of bias, not the same implants, etc. But what we saw is that the kinematic uni was quite safe and with a good efficacy. The rates of revision, tibial loosening, unexplained pain, and fracture were extremely low, and the follow-up of the study ranged from 2 years to 12 years. So my message is this one: the kinematic technique for uni is simple and seems to be safe, and is likely to be clinically advantageous because it's more physiological. So I recommend you, my friends, to keep calm and to switch to KA. And much more, there is much more to come on personalized arthroplasty and kinematic alignment. Soon will be available online a book that is in open access and is about personalized arthroplasty. Also, there is an international society, the P.A.S, Personalized Arthroplasty Society, which soon will be launched, and hopefully will help us to promote and to educate all our community about kinematic alignment techniques. Also, there is a platform to discuss clinical cases. This platform will be soon available with the P.A.S website. And last, we are starting a YouTube channel on kinematic alignment, and hopefully we'll be able to provide you regular basis with some good instructional video, and I will be happy to for you to comment them and ask any kind of question.
So, dear colleague, thank you for listening. I really hope you enjoyed, and see you in the next video. Bye.